So the next topic is whole body scan after the treatment using SPECT. So this is the nuclear medicine evolution in the last years. That is important to repeat because it's a very short period of time. We started with digital images. Most of the young people who is here didn't realize about this, but when we started using nuclear medicine, we were using plaques instead of computers. So this is an evolution from my point of view. So we can look at the image in the computer, and then we can avoid, for example, these areas of high activity, what was not possible in the past, or using just some devices on that. The next step was the SPECT in the 90s. Well, it's difficult to look at the images, but it was important to reflect that some of this uptake could be out of the thyroid area and could be lymph nodes. Of course, at the end of the 90s, from the clinical point of view, because the PET has a long history, but was available in most of the hospitals at that time, or started at that time, so it was important, of course. But there is another evolution that was to put together a PET and a CT, and finally, we have the SPECT-CT, which is in 2007, more or less, available for the hospitals. What does it mean for those who are not familiar with these devices? Well, it's like a sandwich. It's this is the day we started, well, the technicians were just installing all the devices. I was taking pictures about this. So this is the SPECT, and this is the CT. So, and this is the final device once they are combined. So this multimodal, but very close one after the other. This is the two detectors that are just taking pictures of the patient in this way. Well, what are the advantages of these multimodal images? Well, one of them is the attenuation correction, which could be very useful for that, and also the co-registration of multifunctional to look at the location of anatomic areas and diagnostic precision and possibility to use the radiologic contrast in these patients, because we can use the CT just for the attenuation correction, but also we can inject the iodine contrast to better look at the images, so a diagnostic or not diagnostic CT. So these are the questions I'm going to try to address in my lecture. Is what is the clinical value of SPECT-CT? We want to address the help in control of differentiated thyroid cancer, how this technique helps in this control, and how this technique helps in the decision making. Diagnostic impact. The goals of the whole body scan after the treatment are two, from my point of view. One, complete the post-surgical staging, and also to diagnosis, because it could be unknown in a new treatment. For example, this is the remanent treatment, and could be the therapy treatment after, so we can diagnose residual disease or local distant metastases. Well, the diagnostic impact is the more precise location of these high uptake hotspots that you can see in the whole body scan, characterization of this hypertense foci, physiological, could be remnant or could be tumor. Look at these different images from different SPECT CTs. We can see here the esophagus very clearly with some hotspots that could be in some way be misunderstood as some focus of mediastinal lymph nodes. And also here you can see the esophagus also in this area very clearly, or the thymus, which could be in some young people be present and not as some young, but could be different to differentiate or difficult to differentiate from lymph nodes in the mediastinum in some patients. So what is the increase of the diagnostic value along the literature has been presented during the last years? Well, in this paper, with 71 patients, they recognized the increase of the diagnostic value of 57% of the patients. In the group of 10, they said 74, so more or less a little bit more. And in this group, 47, that most of the importance of the increase of the diagnostic value was in the distant metastasis more, in this case, than in the neck lymph nodes. So, and also, which is also important, is the increases in the observer confidence about the location, the precise location of these hotspots in the whole body scans. And in the last one, with a great amount of patients, they found an increase in the diagnostic value in terms of positive foci of 68%, and in terms of patients, 34% of patients had an increased diagnostic value using SPECT CT instead of just the traditional whole body scan. This is an example of one of the paper. So look at the number of lesions that were present in the planar and in the SPECT. So this was read as lymph nodes and metastasis in the planar, but only 5 of these 11 patients were lymph nodes in the SPECT CT. The rest of the patients had not lymph nodes. So it's important to differentiate lymph nodes from residual or physiological uptake of radioiodine. The number of indeterminate foci are clearly reduced by the use of a SPECT CT. So sometimes we cannot say exactly which is lymph node, which is physiological. So using the SPECT CT, we can go further and try to define what is this uptake. And also the thyroid remnant was present in these patients, but 7 of these patients had lymph nodes and metastasis. So this was not a thyroid remnant, but was metastasis, which is important in order to treat this patient. Could be directly to surgery after the whole body scan and SPECT CT. Let me show you an example of this. This is a patient with a clear focus on the left. And what do you think? Is this a lymph node or just a remnant? Well, when we performed, we saw 2 foci. One was posterior, and here you can see very clearly the focus on the CT with high uptake, but also there was another one behind, which is this one is a remnant of the normal tissue. So there are presence of both. So maybe you can say this is remnant, and here you can see there is remnant plus lymph node metastasis, which is very clearly seen in the CT. So the important the CT is also to remark. What about the false positive using this imaging? This is a very interesting study because they are comparing the whole body with whole body plus SPECT, just SPECT, and whole body plus SPECT-CT. But look at the false positive, are decreasing, very high using CT, but there are no false positive in this study using the CT with the SPECT. And the accuracy is also higher using these multimodal terminology devices. In this study, they look at the additional value in terms of metastatic foci or localization metastasis, what is increasing when compared with the normal findings in the whole body scan. What about the clinical value? We have addressed the diagnostic impact, but what is the clinical value of this to see more or more precisely the hotspots? Well, the clinical value is an increase in the detection of the cervical nodes in 35% in this study, or change in the risk staging, which is also important, 25%. And this, in this study, with 81 patients, with stage 1, before the study was the majority, they detected a known lymph node involvement in 22% of this stage 1, which is also important. So it's a low-risk patient, and now we have a low intermediate risk because they have lymph nodes after the stage. This is the TNM. And this is another one. Look at the change in the N status is approximately 36% in the neck, and distant from the neck, the change on the distant metastasis is 21%. So there is a clear clinical impact in the literature. What about this case? So when I saw this, I can say, well, this is remnant or maybe the presence of pteroglossus conduct. And what about this? Probably is very low, so could be lymph node metastasis in the right and also on the left. So it's bilateral. So this is T1 and this could be T1B. Sorry, is N1 on N1B because there are two. When we did this SPECT-CT, we can see, of course, these two nodules on the right, but this was the esophagus. So it's a hot spot in the esophagus, clearly seen here. So it's not a lymph node. So the only side where the lymph nodes were present was on the right. So there is no change in this case, and you can plan the surgery after this study with this combination of SPECT and CT. Well, the risk classification has been also evaluated in different papers. This is one of them. I will summarize this later on in post-surgical and the recurrence, the presence of recurrence. Here you can see the differences in terms of cervical lymph nodes, post-surgery and at the recurrence. These are the presence of normal or negative whole body scans, but there is a group, a small group, with positive in the SPECT-CT. So this group was considered negative in the whole body scan, and using the SPECT-CT you can see some positive scan, positive rest or metastasis. Those after surgery were positive. There are no difference between the two techniques. And look at the equivocal. So the equivocal, as I mentioned before, were easy to differentiate as positive or negative using the SPECT-CT. But when the endpoint is to look at the possible recurrence, the negative also has a small but important proportion of patients with positive findings using SPECT-CT. And those classified as positive, some of them were finally negative because the uptake was in the physiological areas. So that's also important this would be, for example, a patient with no indication of radioiodine because there is no uptake. This is physiological, so you are avoiding an additional doses for this patient. And finally, the equivocal are also well characterized using the SPECT. For distant metastasis, similar findings, so which is also important to this positive. Some of them are negative, and look at the post-surgery differentiation between distant or no distant metastasis. These findings has been summarized in this paper also according to the risk of recurrence defined by the IAEA. So some patients with high risk are intermediate using the SPECT, but also intermediate will pass to high. So this dynamic stratification of the risk that is proposed in these guidelines could be better performed using the SPECT than the regular whole body scan. Change the patient management after these studies. So the change has been determined about 20–30% of the cases, which is not very high, but it's important for these patients, and prevents 20%, as I mentioned before, unnecessary treatments after to look at the physiological deposit uptake in some areas that is a negative scan finally, so we are avoiding some unnecessary treatments. So practical consideration for the use of SPECT should be done in all patients or just in those with only borderline cases. So there are papers for the two possibilities, but in my case, or my suggestions would be all, but only in those patients who are positive findings. So a patient with a negative scan, well, or equivocal will be, well, in some case, difficult to define if this is a good case to perform a SPECT because it takes a lot of time. You are adding some radiation from the CT, so we have to think about that. What about the diagnosis before and post-treatment? So post-treatment, of course, because we are not performing, in general, a diagnostic scan after the surgery as a rule. And what about to aim it a foci with positive with or equivocal? Well, in these cases are, from my point of view, they use equivocal foci with some uptake. You can use the CT in order to look at the structural lesion and look if this structural lesion has an increase or decrease activity of the CT. What about the guidelines? This is the British one that was published last year. So they are, of course, state that the SPECT is helpful to localize the anatomical site of this uptake accurately. So they are suggesting the use of SPECT and also for the dynamic risk stratification. And what about the IAEA published this year? So they mentioned that SPECT radioiodine imaging is preferred over planar imaging in patients with uptake on planar imaging to better anatomically localize the radioiodine uptake and distinguish between likely tumors and non-specific uptake. So in summary, I would say that whole body scan SPECT after the administration of diagnostic or therapeutic, depending on the follow-up of the patient or after the treatment, is associated with an increased number of patients with a diagnosis of metastatic lymph node and decreases the frequency of equivocal findings. The CT by itself, portion of the SPECT provides additional information of no iodine-avid lesions. There is a clear change of tumor risk classification of recurrence in 25% of the patients according to the International Union Against Cancer Classification, or 6% of patients according to this ATA risk I've mentioned during the lecture of recurrence classification. And what about the change treatment management? So it's about 24 or 35% of patients by decreasing the rate of equivocal findings. And finally, avoids the need of further cross-sectional imaging studies such as contrast CT or MRI once we have localized this focus precisely. Thank you.